All right, looks like we have a good bunch, a mixed group today, from people with Parkinson's to care partners and spouses, family, friends, parents, and healthcare professionals. So thank you everyone for joining us today. All right, I'd like to start by saying thank you to our sponsors today for making this program possible: our Acadia Pharmaceuticals, Accorda Therapeutics, Amneal, Kiowa Kirin, and Lundbeck. During this time of social distancing, we hope you're able to stay healthy and safe at home. The Parkinson's Foundation hosts virtual events each Monday, Wednesday, and Friday. To learn more and to register, visit parkinson.org/pdhealth to learn more about our upcoming programs. And before we get started today, I just want to share a little bit of information about the Parkinson's Foundation. The mission of the Parkinson's Foundation is to make lives better for people living with Parkinson's disease by improving care and advancing research today until there's a tomorrow without the disease. In everything we do, we build on the energy, experience, and passion of the global Parkinson's community. We provide free resources, including our website, parkinson.org, educational book series, webinars, podcasts, and our hospital safety kit called the Aware and Care. We also have a toll-free helpline at 1-800-4PD, which is staffed by Parkinson's specialists. We invest more than $10 million annually to support the most talented minds in research to explore what causes Parkinson's, how to treat it, and ultimately how to cure it. We recently launched a very exciting initiative called PD Generation, which provides free genetic testing and counseling to those with a Parkinson's diagnosis. To learn more and get further information, please visit parkinson.org/PD Generation. We also bring together local communities for Moving Day, a walk for Parkinson's, a national grassroots effort that's nearly raised $27 million to support Parkinson's research and local wellness programs across the country. For more information, visit movingday.org. And we also just finished up our Fargo-Moorhead Moving Day, so we're still in the last days of fundraising. So at the end of this program, I'll be sending out information and this link, and I'll send that Moving Day Fargo-Moorhead link as well. All right, as we get started with today's program, just a few things to keep in mind as we're asking questions of Dr. Harlow. Click that icon, the chat icon, and type your question. We will do our very best to get to all the questions that are submitted. And Dr. Harlow will also do her very best to answer the questions. Just may not be able to get to those specific questions, as each person is unique with Parkinson's. You may have individual needs, unique symptoms. So we recommend you connect with your provider or the nurse line for any specific or personal questions. And also know that the Parkinson's Foundation helpline is also available to provide education and support. All right, and with that, I'll go ahead and get us with Dr. Tanya Harlow. So she is a movement disorder specialist with Sanford Health. Let me just get her unmuted here so she's ready to go. There we go. She earned her medical degree at the University of North Dakota School of Medicine in Grand Forks, North Dakota, and completed her residency in neurology and a fellowship in movement disorders at the University of Iowa Hospital and Clinics in Iowa City, Iowa. So thank you, Dr. Tanya Harlow, for joining us. I know this has been a very busy time with many things going on in your schedule, so we greatly appreciate your time with us today.
Well, thank you so much for having me today, and we'll see how this goes. I don't know, maybe you guys will stump me today, and we'll no guarantees, but we'll do our best to answer your questions.
Absolutely. Okay, I think we've got a few questions that were submitted during registration. So I thought maybe we could start with kind of the understanding of Parkinson's and start with a little basics, get the baseline set. So let's talk about the diagnosis of Parkinson's. Can you walk us through what that would look like at an appointment in your clinic?
Absolutely. So generally speaking, Parkinson's disease and Parkinsonisms, which I guess we can talk about both of those questions that you kind of had, Erin, is a clinical diagnosis. And so a lot of it is based on the history and what you're telling me has been going on, but also on the clinical examination. And so to diagnose Parkinsonism, you have to have 2 of 4. So any 2 of the following 4 things that we would look for on your examination. So the first thing that, and really the most recognizable sign specifically of Parkinson's disease would be a tremor. And that's primarily a resting tremor. And when I say a resting tremor, I mean your hands are fully supported against gravity. So they're resting on your lap or they're resting on a table, but you're not holding them up or doing anything with them. Now, about 30% of people with idiopathic Parkinson's disease do not have any tremor. So while it's recognizable, people that don't have tremor actually end up getting diagnosed later because their primary care physicians aren't recognizing it either. And so they're not sending them on for further evaluation. So keep that in mind, is that you don't have to have that tremor. The second thing we look for is rigidity or stiffness. And so what we do there is I move your arms and your legs around to see if you feel stiff. And so those of you that have been in my clinic and I tell you to relax and to relax and relax, that's why, because I'm trying to differentiate, are you just not relaxing for me or do you actually have some rigidity or stiffness? Because it's really important in that diagnosis. The third thing that we look for, and actually it's the most important, the one of the 4 that you absolutely have to have, is something called bradykinesia. Bradykinesia is a smallness of movements. So I tap big and wide, and somebody with Parkinson's, they get smaller. I open and I close big and wide, and somebody with Parkinson's may not get all the way open. I turn my hands over and back all the way, and somebody with Parkinson's may not get all the way over. Now there's varying degrees of that, and sometimes that can be really mild and subtle, and sometimes it can be really severe and obvious. And we also look at that with toe tapping as well. The last thing we look for is something called postural instability. It has to do with a change in our balance reflexes. So that's when I give you that big tug backwards and I see if you're able to kind of stay where you are. Do you need to take some steps or do I need to actually catch you? For true Parkinson's disease, that tends to be something that occurs later on in the course of the disease. So it's not something we typically expect to see early on if you have early symptoms of that. And so once we make a diagnosis of Parkinsonism, because that doesn't differentiate between Parkinson's disease and other forms of Parkinsonism, then we have to kind of look at the history, the examination, and then response to treatment after, if we do start treatment and after that. So Parkinsonism is just a big group of disorders that includes those signs and symptoms. So the very most common form of Parkinsonism is, of course, Parkinson's disease, the one we all know about. 70% of Parkinsonisms are Parkinson's disease. And then there's another 30% that are other things. And that may include dementia with Lewy bodies. It may include progressive supranuclear palsy. It may include multiple system atrophy, corticobasal degeneration, vascular Parkinsonism, drug-induced Parkinsonism, and then a whole long list of other things as well. For idiopathic Parkinson's disease, generally speaking, symptoms should be asymmetric. So it usually starts on one side and moves to the other side. Whereas the other forms of Parkinsonism are often much more symmetric. So that sometimes is an key that this is probably just going to be Parkinson's disease before we even start medications. But truly, we don't have any testing that differentiates really these different forms. If it's unclear, maybe there's subtle signs of Parkinsonism, sometimes we do a test called a DAT scan, which is a test that looks at the dopamine uptake in the brain. And dopamine is the chemical that's decreased or low in the brains of people with Parkinsonisms. So it will tell us if you have Parkinsonism or not. It doesn't differentiate between forms of Parkinsonism. And so, the caveat is almost all the Parkinsonisms will be positive on a DAT scan with the exception of vascular Parkinsonism and drug-induced Parkinsonism. And so that can sometimes be helpful in confirming a Parkinsonism, but again, it doesn't differentiate it. We don't use the DAT scan to monitor symptoms or progression, so it's not approved for that. So we never repeat it. It's a one-time sort of test that we do. I mean, sometimes we'll repeat it if there's problems with doing the testing, but we never repeat it typically for other reasons from that standpoint. And then as far as medications, Parkinson's disease would be expected to be the most responsive to medications. And those are the dopaminergic medications. The gold standard would be Sinemet or carbidopa-levodopa. And that's the one that 100% you'd need a response to, although you may need higher dosages to determine response. If your symptoms get better and stay better in the long run, then you are off of medications. That's how we make a probable diagnosis of Parkinson's disease. Otherwise, the only way to diagnose 100% would be to do take a piece of your brain and look at it under a microscope, and we don't do that while people are alive. So now there are certainly brain donation programs, though, that there, if there's an interest or it's unclear diagnoses during life, some people do consider doing that later on.
Okay, great. Another question, what's the average age of diagnosis?
So the average age can vary really wildly. The age itself can vary widely, but the average age is late 50s to early 60s, so maybe around the age of 60-ish. Different studies have shown kind of a little bit of difference in that. If you develop Parkinson's disease before the age of 50, we generally consider that young onset Parkinson's. And that happens, and I think the number I've seen is 10 to 20% of people can develop young onset, so before the age of 50.
Okay. Another question we hear often is, what are the causes of Parkinson's? And do you have a higher risk if a family member was diagnosed?
So Parkinson's disease in general is not considered a genetic disease like most things like, say, Huntington's disease that I treat. Parkinson's disease in a small number of families can be genetic, where it's passed down from parent to child, in an autosomal dominant manner, where each child will have a 50% risk, or in an autosomal recessive, where there's a 25% risk if both your parents give you a copy of the genetic defect. For the most part, we think that it's a combination of genetic and environmental factors, so that you may have a genetic abnormality, but you also need to have some sort of exposure to an environmental impact for the disease to become active. And so if you have a genetic predisposition and you're exposed to that, then potentially you are more likely to develop Parkinson's disease. There is a lot of genetic research going into genetics, and there's been actually, I think there's over 20 Parkinson's genes that have now been identified within that. So there is a lot of research, and when we talk about research, we'll talk about kind of how that may play a role later on. When we talk about environmental factors, there's a lot of different environmental factors that play a role. It's not generally thought to be just one thing. After the 1918 Spanish flu pandemic, there was actually an outbreak of Parkinson's patients that were called post-encephalitic Parkinsonism that developed Parkinson's disease after they had that flu virus. Now, the coronavirus is a totally different virus than the influenza virus, but people are losing their sense of smell with this. So this is something that the movement disorder community is interested, whether people with this new coronavirus may be more likely to develop Parkinson's disease as well, because some of them lose loss of smell and taste with that, which is a common early sign of Parkinson's disease. Other environmental factors, probably one of the most common things that we see potentially would be exposure to herbicides and pesticides. So when we look at populations that have a high farming community, I think the last I heard when you're looking at those numbers per capita, the states with the highest number of Parkinson's patients would be Nebraska, followed by, and this is per capita, which is a little different than your PD generation study, which is looking at total numbers. But looking at Nebraska, followed by South Dakota, North Dakota, Minnesota, and Iowa. So the Farm Belt really plays a role in that. And I think I saw something actually during the Movement Disorder Society meeting, which is an international meeting that we just had this last week virtually for the first time, about paraquats specifically being potentially exposure to those being a risk factor. So people that have Parkinson's in their families, if it's not genetic, which again happens in maybe 5 to 10% of cases, their family members, if you have a parent or a close sibling family member with Parkinson's, your risk is slightly higher than that of the general population. And we generally say the risk for developing Parkinson's disease after the age of 60 is maybe about 1% of the population. And so people with a family history, their risk is about 2.5 times higher, so maybe about 2.5%. So it's not the 25% or the 50% risk, but it is a slightly higher risk than the general population.
Okay. All right, there's two categories of symptoms, non-motor and motor symptoms. You've talked about the motor symptoms. Non-motor seems to be ever growing and so many questions about it. We had a few that were submitted about mild dementia and constipation. And are those related to Parkinson's?
Absolutely, they're related to Parkinson's. So constipation actually is one, potentially a really, really early sign of Parkinson's disease. And can happen many years before onset. We think actually that Parkinson's disease probably starts in the gut before it moves into the brain. And so I would say the vast majority of people with Parkinson's, 80 or 90% of people with Parkinson's disease will have experienced at some point or do continue to experience difficulties with constipation. So it's really, really common, and it's really an important thing that we make sure that we're treating. Additionally, the medicines that we give to treat Parkinson's often makes the constipation worse as well. As far as dementia goes, unfortunately, people with Parkinson's disease are at higher risk for developing dementia. I think the numbers are anywhere between 50 to 70% of people, if you live long enough, may develop dementia. It's not the same type of dementia that we think of with Alzheimer's dementia, where people have terrible, super bad memories and they don't remember who their family members are. They can have mild memory troubles, but it's not typically to the same extent that we see in people with Alzheimer's dementias. And so the main kind of characteristics of Parkinson's dementias is that executive functioning is often affected, and that can include things like organization, planning, as well as judgment. And often judgment is really one of the really harder things to kind of deal with. And then it also can affect what we call visuospatial functioning. So how do we see the whole world? Are we missing pieces of the world? And that piece of it. And so sometimes it's not as obvious that people are having dementia because it's not the strict and straight memory pieces of it. It's other ways that are affected. And really the best way to evaluate that is to do something called neuropsychologic testing. That's a half day of in-depth memory testing that really gets to what's actually going on with memory and thinking. And is this normal aging? Is this due to Parkinson's? And if that's the case, there are medications that we can give to treat memory changes that actually, even though they were approved for Alzheimer's, they tend to be more effective in patients with Parkinson's disease. So.
I did not know that. That's a good tip. Good to know. All right, talking about other symptoms. Is sleep affected by Parkinson's?
Absolutely, 100% yes. Those of you that know me, I've probably tried to send you all for a sleep study at one point or another, but that's because sleep problems are really, really common in people with Parkinson's disease. So there's lots of different things that can occur in people with Parkinson's. First off, sleep apnea is something that I'm always screening for. It's not necessarily more frequent in people with Parkinson's disease, but it's a common thing that 100% will affect your functioning if you're not getting good quality sleep. But other things that can occur in people with Parkinson's disease related to their sleep is people can have troubles with sleep fragmentation. So for not entirely clear reasons, sometimes patients may be not being able to stay in restful sleep and popping out of that where there's not a clear indication. Sometimes that happens when patients' Parkinson's medications wear off. And so sometimes just adding in Parkinson's medications at bedtime and in the middle of the night if you wake up can really be helpful in improving sleep quality. There's something called periodic limb movements of sleep. It's a cousin to restless legs. Restless legs occurs while you're awake and you have a discomfort or creepy crawly in your legs, which also can be more commonly seen in people with Parkinson's disease. But the periodic limb movements are leg movements that don't necessarily feel uncomfortable, but your legs are moving all night long. And that can also result in what we call arousals from deep restful sleep into lighter sleep so that your sleep is not restful sleep. And that's actually a fairly easy thing that we can treat with medications. Some of the Parkinson's medications help that, as well as medicines like gabapentin and clonazepam can also help them. And then one of the really more common things that we see is something called REM sleep behavior disorder. So when we're in REM sleep, those of you that don't have this disorder, our bodies become paralyzed. And in people that have REM sleep behavior disorder, that paralysis is lost. And so people will often have these really vivid dreams. And then because they're not paralyzed, they can actually act out those dreams. And they may hit, they may kick, they may yell. There's been spouses that have gotten black eyes. So it's actually potentially dangerous. People sometimes get out of bed and do some crazy things. And so that can also be quite disruptive to sleep and can be bothersome as well, especially to the spouses who may be getting poor sleep because of it as well or getting injured. So, that also is a treatable disorder that actually, and by the way, REM sleep behavior disorder is also potentially a very early sign of Parkinson's disease. So like constipation, REM sleep behavior disorder, loss of sense of smell, depression and anxiety, all can be early signs of Parkinson's. And actually the more of those signs that people have, the more likely they are to develop Parkinson's disease down the road. But REM sleep behavior disorder being like probably the most, the biggest sign that you may develop Parkinson's disease or Lewy body dementia in the future. So the treatments for the REM sleep behavior disorder include melatonin, which you can get over the counter, as well as a clonazepam. So clonazepam is an anti-anxiety medication, but it's also been found to be effective for the treatment of REM sleep behavior disorder, as well as the periodic limb movements of sleep.
Great, thank you. Just to follow up, you said those 5 things like the REM sleep cycle, constipation could be early signs. Is that before movement symptoms start or is at the same time?
Right, so that's a great question. So here's the thing, you have to lose about 60 to 80% of the dopamine producing neurons in your brain before you develop the motor signs of Parkinson's disease. So those other signs we were talking about, we call premotor signs. And so those things, you know, have been occurring for many years because the disease has been going on for many years, but we're not actually able to make the diagnosis until we see those motor signs of the disease. But definitely some of the changes that have been going on for 10 or 20 years may just have been going on because you've had early Parkinson's for that period of time.
Okay, thank you for clarifying that. Another symptom, swallowing when eating and drinking. Any recommendations on what to do if you're experiencing that symptom?
Make sure you talk to your doctors about that because that's a really concerning symptom. It's common in people with Parkinson's disease, but if you're getting food or liquids in your lungs, that's a risk factor for pneumonia. And pneumonia is potentially life-threatening, okay? And also right now, nobody needs to be in the hospital if they don't need to be in the hospital. So we want to keep as many people out of the hospital as we can at this point. So what my recommendation generally is I often will get a video swallow or a cookie swallow, it's sometimes called, where you would meet with a radiologist and a speech therapist and they trial different textures of food and liquids and make sure it's not getting into the lungs. And so depending upon what that study shows, sometimes the speech therapist can give exercises that can help to strengthen the swallowing muscles, or tips, maybe you need to tip your chin down before you take a swallow to help with that. But sometimes we also need to adjust the textures of the food or liquids to also reduce that risk. So sometimes thickening liquids or eating softer foods can make a big difference as well. On rare occasions, sometimes we talk about feeding tubes. I would say that's pretty rare for most people with Parkinson's disease, but it does come up on occasion. You know, if people are having such troubles with swallowing that anything they eat or drink is getting in their lungs, sometimes that would be a recommendation. Just because we put a feeding tube in doesn't mean to stay in forever. We can always take it out or stop using it at any point. Sometimes if people are losing a lot of weight, we'll talk about a feeding tube where you can get most of your nutrition through the feeding tube, but maybe you can still do some eating and drinking for pleasure as well.
Great. Going back to sleep, we just got a question. I'm not sure if I pronounce this correctly, but Nocturia or frequent night urination,
Yeah.
precursor to Parkinson's?
So, you know, Nocturia, which is the frequent urination at night, is actually really common in people as they get older. So no, I wouldn't say it's necessarily that if you have that you're likely to go on to have Parkinson's disease. It can be for many reasons. For men, they might have an enlarged prostate. Women sometimes have bladder issues as they get older from prior childbirth things. So I wouldn't necessarily consider that, but it certainly can also interrupt sleep quality as well. So I always recommend that you check with your primary care physician and make sure you've had a good exam. Maybe we need to send you to a urologist to evaluate that. Sometimes Nocturia gets better by adding the Parkinson's medications in overnight. So sometimes that will get a little bit better if we add in some Cinemet carbidopa-levodopa overnight. Sometimes it reduces it. Sometimes people have Nocturia actually that have sleep apnea or periodic limb movements of sleep. So that because they're not staying in deep restful sleep and they're popping into lighter stages of sleep, when they're in that lighter stage of sleep, then their body, they're kind of sort of half awake, you know, sleeping, not really aware, but half awake. Maybe my bladder's irritated. So you get up to go to the bathroom more frequently. But if you treat a sleep disorder, if you have one, like, so there's lots of people actually that when you treat them with sleep apnea, with a CPAP, they're staying in that restful sleep more. And so they're not getting up nearly as often to go to the bathroom. There are also medications that might be helpful in reducing that as well, which again, would recommend discussing with your primary care physician or urologist on that.
Follow up with sleep. What helps to diminish any nocturnal wandering? Is that common with Parkinson's? And
well, so nocturnal wandering is a little tricky because it could be occurring for many reasons. It might be related to a REM sleep behavior disorder where somebody's waking up from this weird dream and kind of acting that out still, or they're still kind of partially asleep. It could be related to other sleep disorders. So first off, it's probably important that you be seen in the sleep clinic to try to determine what's causing that, because the treatment may vary depending on what is the actual cause for that. And so, you know, I think that would be my first step, would be to get a sleep study and see what that shows.
Great.
Or are you getting up just because you're sleeping all day long and you know, so that's another thing, is trying to reverse the sleep-wake cycle back into where you're sleeping at night, not sleeping all day during the day.
Right. 2 long naps. Cut those naps in half. All right. So we've got a lot of questions on medication.
Okay.
Are there ways to increase dopamine levels naturally, as some websites proclaim this?
Well, I guess I'm not familiar with the websites. There are, I mean, so potentially exercise could potentially naturally increase your dopamine levels. So that's something that is probably a good point, that exercise is actually, when you look at the things that you can do on your own, it's one of the very most important and beneficial things that you can do to improve your Parkinson's symptoms. There's been hundreds of studies on Parkinson's and exercise that have all shown benefit. When they compare types of exercise, it seems to show more benefit the higher you get your heart rate up. But really all kinds of exercise has been found to be beneficial, and it may possibly slow progression of disease as well. There's some indication for that. So I generally recommend find something you like that you think you can sustain. You know, if you're probably not going to be a marathon runner if you never were before. So maybe that's not the goal, but finding something that you can do on a regular basis is a great idea. There is a bean called the fava bean that contains levodopa. The problem with that is trying to determine the amount of levodopa that you would need to take, or the amount of fava beans that you would need to take and eat, and how many times a day you would need to eat them. And I would think you would get really sick of fava beans. Additionally, fava beans don't contain carbidopa. So carbidopa's job in the carbidopa-levodopa combination is carbidopa prevents the breakdown of levodopa to dopamine in the bloodstream, so that the levodopa is breaking down into dopamine, and dopamine can't cross from the blood to the brain. And it actually causes side effects of nausea. So I actually have had one patient in the past that did fava beans, but he got super nauseous from them because there was no carbidopa component. When levodopa initially came out in the 1960s, it came out as levodopa by itself. And you had to give really, really high dosages of levodopa to get enough into the brain to be effective. And people were super nauseous. So that's when carbidopa got it added in. It's called, they have another one, similar medication called bensericide, in I believe Canada and Europe, that does the same job as carbidopa, but it helps make it much more tolerable, and it helps to get more of that levodopa into the brain.
Great. A lot of questions about NOH, neurogenic orthostatic hypotension.
Right. So this is also a pretty common problem in people with Parkinson's disease. And there's various things that we can do. My but for those of you that don't know, neurogenic orthostatic hypotension is due to a drop in blood pressures when you stand, and it makes people dizzy and feel lightheaded, and sometimes people actually pass out from that. The very easiest things that we can do is increase water intake. So water, first of all, none of us really drink enough water unless we're really thoughtful about it. It's just, there's all sorts of other things that taste better, and we drink those things, and we don't like the taste of water. And if I drink too much water, I have to go to the bathroom too much. So there's lots of things that play a role in that. But water is really so important. And so and those of you that know me, I'm sure I've given you all this advice about the water that you need to drink, right? So I said, there's not a perfect known amount of water that's perfect. My goal for people is about 64 ounces. That's 8 ounce glasses of water per day. I follow my own advice, and I drink 2 glasses of water with each meal, and I drink a full glass of water in the morning and the evening with medications. If you're taking a Parkinson's medicines 3 or 4 times a day, if you do a full glass of water, so instead of a sip, you're thoughtfully drinking that whole glass, and then you drink a glass of water with each meal, you're probably set for the day. And so that can be really helpful. Sometimes we can also add in things like saltier fluids, V8 juice, Gatorade, all have a little extra salt. The salt can help prevent the blood pressures from dropping when you stand. If you have a heart disease or other reasons you've been told not to eat a lot of salt, you may need to speak with your other doctors about that. Sometimes people have had high blood pressure their whole life, and when they get Parkinson's disease, their blood pressures go down, and they may no longer require the blood pressure medications like they have in the past. So sometimes, especially people that are passing out, we send them back to their primary or the cardiologist or the kidney doctors that are prescribing those medicines and say, hey, can we try a lower dosage, or can we get off these medications, and then see where we're at with that. There are also other things you can do during the daytime is keep your feet elevated as much as you can in a recliner or some other way. That can also prevent some of the drops in blood pressure when you stand. Sleeping with your head of the bed elevated about 30 degrees. I can give you an abdominal binder or thigh-high compression stockings that are really, really tight. And that can also be helpful, but they're really hard to get on, and most people don't usually end up wearing them kind of for long periods of time just because of the difficulties getting them on and off.
Can you just repeat the bed piece?
The head of the bed. So yeah. Elevating it at about a 30-degree angle. So for people that have like motorized, you can do that. Some people have put bricks underneath their bed, the head of the bed, to kind of get that elevated that way. And then actually, if you go to a sleep store, somewhere that sells CPAP supplies, they also have wedges, sleep wedges. You can probably get them on Amazon as well that are sort of at those 30 degrees, and you can put your pillows on top of that to keep your head elevated. So that can sometimes be helpful, especially first thing in the morning when you get up, which is probably the time people are the wooziest because they haven't drank overnight and they're more dehydrated at that point. There's also medications that can be helpful. So I usually reserve these medications for the most part for people that are having pretty significant symptoms, especially if they're passing out, because we certainly don't want them to fall and hurt themselves. And so medications that we use, the problem is they can increase your blood pressure, right? So we have to be a little cautious with them. Would be a medicine called fludrocortisone or Florinef, another one called Midodrine. And then there's a newer medication that was FDA approved in the past, 5 or 6 years or so, maybe a little longer, called Northera or Droxidopa. And so these medications can help to bump the blood pressure up, but we just need to be cautious we're not getting it too high either. Sometimes the problem is that people with Parkinson's disease can get really, really high blood pressures and really, really low blood pressures. And then it becomes really hard to kind of sort out how best to treat that. Additionally, if you're on medications that I had just mentioned, we recommend that you don't lie flat during the daytime to nap because you have the risk of getting really, really high blood pressures. We generally want to keep those blood pressure medications, I would say last dose no later than 5 p.m. So we're not getting it so close to bedtime. If you need to nap during the daytime on those medicines, make sure that you're napping in a recliner or with your head elevated.
I did not know that recliner tip. So
yeah.
All right. How can you tell if someone's over medicated?
So over-medication generally is side effects, right? So it's a side effect profile. For the medicine Sinemet or carbidopa-levodopa, the very most common sign of being over-medicated is dyskinesias. So dyskinesias are the wiggly movements like Michael J. Fox, where it tends to get worse in the middle of a dose and then may get better as the medication wears off. Unfortunately, though, people with Parkinson's can have dyskinesias even when they're not over-medicated. But if you're having them really, really badly, then some of the treatment may be just trying to lower your dosage of medication. Quite honestly, there's not really a maximal dosage of Sinemet or carbidopa-levodopa. It's sort of the dose that people need and they tolerate, right? So we adjust it based on their symptoms, but also on their side effects. And so, that's kind of the primary way I would say that we would evaluate that.
So therefore, so many appointments because you're always kind of tweaking a little bit.
Correct, right? And that's why you have to see your Parkinson's doctor so often, is things are constantly changing and we're trying to tweak and we're trying to find the right dosages. Yep.
Okay. And can you speak a little more about the Sinemet side effects?
Sure. So the side effects of Sinemet, carbidopa-levodopa, can include nausea. Again, so sometimes the treatment for that is just more carbidopa. It can also include constipation, dizziness and lightheadedness with standing. Hallucinations can occur, but generally if you're only on Sinemet, not on any other Parkinson's medications, hallucinations actually, and they tend to be visual, are usually a sign to me, even if the medicine is making it worse, it's usually a sign that we're probably developing Parkinson's dementia at that time, and would be a trigger for me to get neuropsychologic testing at that point, because hallucinations rarely occur in Sinemet in patients that don't have memory or cognitive issues. And then the dyskinesias and motor complications, like troubles with medications wearing off. And that tends to become more problematic over time. Patients develop motor complications within 50 to 90% within the first 10 years of treatment. And so those things tend to occur to some extent, like levodopa itself is really short acting. And so the half-life is only 90 minutes. Initially, when we give you medication, you probably take it 3 times a day, but you also still have some dopamine cells in your brain that are still functioning, and so it sort of supplements that. And over time, as those cells die off, what we see is more and more need for medication and adjustment of medications. And then as that's occurring, dyskinesias tend to occur even at the same dosages, or we're increasing dosages to improve symptoms, and then we may yet see dyskinesias as we increase dosages.
Okay. How can you tell the difference between Parkinson's and Lewy body?
Right. So the terminology gets a little tricky. Lewy body dementia specifically encompasses both dementia with Lewy bodies as well as Parkinson's disease dementia. Lewy bodies are the hallmark of both Parkinson's disease and dementia with Lewy bodies, as well as Parkinson's with dementia. So the dementia tends to occur early in dementia with Lewy bodies, where you develop Parkinson's symptoms within a year of onset on either side of memory and thinking problems and hallucinations. Parkinson's disease dementia occurs if you develop dementia over a year after your diagnosis of Parkinson's disease, often longer than that. The Parkinson's disease itself should not have cognitive difficulties. If it does, then you've had it for 10 years and now you're having cognitive difficulties, we call it Parkinson's disease with dementia. But quite honestly, when people get dementia due to Parkinson's and dementia with Lewy bodies, they look pretty much identical. I mean, they have the very same symptoms where the neuropsychologic profiles are very similar, showing the executive dysfunction and the visual spatial changes. They both have visual hallucinations associated with them, and they both tend to have a fluctuating cognitive profile. So really, it's a time frame onset is really what differentiates Parkinson's dementia from dementia with Lewy bodies, but they both technically fall under the umbrella of Lewy body dementia. I hope that made sense. I feel like it was a little bit.
So you have Parkinson's diagnosis, and if you develop dementia, it's Parkinson's with dementia.
After a year.
After a year.
As long as it's been more than a year since the diagnosis.
Okay.
Right? Yeah.
And then if you have dementia and develop Parkinson's symptoms, more likely Lewy body.
Yeah. Yeah.
All right.
But it's really thought to be a spectrum of the same disease. So most experts would say, it's probably semantics. You
treat those differently then?
No, we treat them the same. I mean, if you develop early memory troubles, I might hold on starting Parkinson's medications until I've got some of the cognitive pieces a little bit better controlled, but they still often will respond to a low dosage of levodopa. But I treat Parkinson's disease dementia, I treat the dementia exactly the same as I would dementia with Lewy bodies.
Are seizures a common part of Parkinson's?
I would say no. I do have a few patients that have had Parkinson's disease and also have seizures, but I would say that's not something that would be commonly associated. I think it's just the unluck of having two neurologic disorders. I mean, unless there's maybe a reason, if it's a vascular Parkinsonism because you had a stroke and then that causes a seizure focus, but Parkinson's disease itself does not have an increased risk of seizures.
We have a question from registration about pain, as their fathers lived for 15 years with Parkinson's. Chronic neck, back, shoulder pain, and sometimes all over, he describes. Any recommendations as he's tried the gamut of physical therapy, behavior therapy, some anti-anxiety medications, and other medications to reduce pain?
Yeah, so pain can be a common part of Parkinson's disease. Sometimes it's hard to differentiate because low back pain is common and sometimes people with Parkinson's have back pain. Oftentimes pain due to Parkinson's disease may be because of dystonia, which is a twisting, turning of muscles, and that actually can sometimes occur in people as a sign of the medicine wearing off. So sometimes treating the wearing off can help to improve that. Sometimes, and there was actually a study a few years back that showed that about 70% of people with Parkinson's disease also were found to have neuropathy on examination. And so neuropathy is a dying back of nerves, which can sometimes be painful. So sometimes treating neuropathic symptoms, sometimes actually Parkinson's medicines themselves I've found have helped numbness in people that have neuropathy, probably due to Parkinson's. If adjusting the Parkinson's medications aren't effective, Botox, botulinum toxin injections, if it's like people develop cervical dystonias or toe curling dystonias, sometimes Botox can really help to reduce those symptoms and improve the pain. Some of the other medications that we use for neuropathic pain, like gabapentin, sometimes can also help anxiety. Also, there's a medicine called Cymbalta or duloxetine, which is an antidepressant, may help anxiety, but also is approved to treat nerve pain and diabetes. So that might also be something to consider. And then if you haven't, I would certainly, you've tried all those things, it's not helping, I would send you to the pain clinic and see if there's other options or reasons for your pain that we can potentially treat as well.
Okay. Moving on to living with Parkinson's. A few questions came in on how to address anxiety and depression and motivating that person with Parkinson's, or even they're doing the exercises, but it just doesn't seem to be helping.
Yeah. So let's start with the depression and anxiety. So this is so important because when you look at studies that look at quality of life in Parkinson's patients, the number one factor that affects quality of life isn't that I have a tremor or I have troubles walking or I have bad troubles with my memory and thinking. It's actually mood. And so that we should 100% absolutely treat. If I can improve your quality of life just by treating that, we should. And depression and anxiety are super common in people with Parkinson's. And it's not just because you're living with a chronic disease. Depression and anxiety in one study was found to be more common in people with Parkinson's than in ALS or Lou Gehrig's disease, where people die within a couple of years. Okay, so there's changes in the brain that occur that are probably more than just dopamine to some of the other neurotransmitters or chemicals in the brain like serotonin and norepinephrine that probably affect that. And so, first off, make sure that you're telling your providers that you're having these troubles. That's something I ask my patients at every visit to make sure that we are addressing this. And please don't be embarrassed about it. There's nothing to be embarrassed about. It's part of your disease. There are lots of different medication options that we can consider. And so that's something that we would potentially talk about. Sometimes it's helpful to either with or without medications, making referrals to psychology or counseling to do talk therapy. And actually, studies not necessarily with Parkinson's, but just for depression in general for people, found that the combination of medication with counseling or working with a psychologist actually worked better than either one by itself. Okay, so that's really an important piece of that. And if we just can't get the mood and the memory, or the mood and the depression and anxiety controlled, if we've tried lots of medicines, I will often send you to see my psychiatrist, who is an expert in the treatment of mood disorders. And so there's lots of different options and things. There's lots of newer medicines that we can try, but really important. Exercise also probably helps with mood and depression, anxiety as well. So those would also be important things. One other kind of caveat to the depression thing, especially anxiety, can sometimes be a sign of medication wearing off. And so that would be something important to monitor. Do I get anxious intermittently? Is it occurring 30 minutes or an hour before my next dose is due, and then 30 minutes after I take my dose, or an hour it gets better? That would be a sign that maybe adjusting your medications just might help your mood symptoms as well. I forgot the rest of the question.
No, you've encapsulated all of it. Just how about a care partner or a spouse? Do you recommend they also speak to someone? Because I'm sure it's a burden.
Yeah, absolutely.
To see their loved one.
And caregiver burden is really, it's a thing, and it's really important. And I always tell caregivers when they're overwhelmed, like, look, if you can't take care of yourself, you can't take care of somebody else. So we need to get you extra help, maybe in the home, or maybe we need to think about alternative living situations. But it's important too that that the caregiver gets a break and gets some help. I know it's always hard to have the conversation about maybe a move to assisted living or a skilled nursing facility or a higher level of care. But what I've seen is that people struggle, caregivers struggle with this. I don't want to send them there. I feel terrible. They feel guilty. But when it comes down to it, when they finally get there, everybody's so much happier because there's not that same stress. And so actually the relationship with your loved one actually often improves because there's not always you need to do this, you need to do this, and now you just get to be spouses again, and somebody else does all of the rest of those burdensome tasks. So, or bringing somebody in the home to help out with some of those things really can make a big difference.
Are you seeing more with the current pandemic? More people accepting help or even sharing, or any of your colleagues? Or is it?
Well, I just think that that's just there all the time. So I'm not sure that it's necessarily more, but it would make sense maybe that it is because everybody's at home all the time together more than they maybe used to be. But I think that caregiver burden is always there. Definitely for depression and anxiety. I think that anxiety specifically has been a lot higher during the pandemic, but also depression to some extent as well, because it's tough times and we miss seeing all of our family members and visiting with people and going to our support groups and, seeing people in person. Whereas the human race is a very social race. And so it's hard sometimes when we're all stuck inside and Zooming each other even.
Right.
It's nice to be able to do this and see you, but it's not the same necessarily. So.
No, it's very different. But at least we can see some smiling faces today. So thank you for being here with us. We've got a few more questions before we hit our time. Just thinking about some of the research, as you touched on, do you have any highlights or things you want to share that you're looking forward to?
So, I think research is a really exciting time right now. There's a lot of really cool things going on in Parkinson's. When we look at actually just treatment of Parkinson's symptoms, there's some newer treatments looking at how to better deliver levodopa. There's lots of problems with levodopa's delivery. As any of you know on the medication, there's concerns with the absorption of the medication when you get too much protein at the same time. And so we're looking at different deliveries of that. One is a pill that is sort of a prodrug to levodopa so that the absorption is not impeded, but once it gets absorbed and then gets basically converted into the carbidopa levodopa, which would be a really big thing. And then there's also a new trial ongoing, which we're actually in startup for. So for people that are having a lot of off time, or your meds are wearing off, let us know. We're going to be doing a trial on a carbidopa-levodopa pump. Basically, it's delivered through a patch system, and you get a constant delivery of it through a patch. Sort of like Duopa goes through, you get a constant low-dose infusion through your belly. This will be going through the skin. And so that we're going to hopefully be up and going fairly soon in that. And so that would be also another new way to deliver the medication. They are also looking at some different potentially disease modifying therapies. So things that might slow the progression of the disease potentially. Alpha-synuclein is actually the pathologic hallmark of the Lewy body. It's an abnormal protein folding. And so there's several new trials upcoming looking at if we can prevent further spread of alpha-synuclein. We don't know if that might be too late down the road, but we're hopeful maybe that might be beneficial. You were just talking about your PD generation trial, and you guys are looking at the different gene markers. There are actually upcoming several phase 1 trials looking at people that have specific genes. So there probably are lots of you that have abnormal genes that don't necessarily mean you have a genetic form. So specifically the LRRK2, the LLRK2 gene, and then the GBA gene, and I'm forgetting, it's a glucocerebrosidase, I can't say it, gene mutation. So, you know, as we're thinking about getting into more specific medicine for people and what your specific, so they're looking to see, hey, do these medications work for this specific group of people? And so maybe in 10 years, you'll all have a different treatment based on if you carry a specific gene or not. And so that's pretty exciting as well. There's some other drugs in trial as well for that. But really, it's an exciting time, I think, for Parkinson's disease. And, you know, I think this is kind of the most hope I've had that maybe we're getting closer to a cure.
That's good news to hear.
Yeah.
In sharing about your clinical trial that's happening, is there any recommendations or things that you would tell someone to consider before participating?
So clinical trials are not for everybody. Clinical trials, though, if we don't do them, then we don't develop new therapies and we don't develop new treatments, because until we, 1, decide if they're safe, and 2, decide if they're effective, none of these things are going to come to market. So, you know, drug trials are, and I know that lots of people have expressed to me their interest potentially in being in trials down the road. Drug trials are really usually very specific about who can participate and who can't participate. So, you know, when people tell me they're interested in trials, I give them their name to our study coordinator, and if a trial comes up that would fit for them, we'll certainly contact you. So that's the first kind of step from that. One thing you do need to be aware, though, is if you're in a trial, you may or may not get treatment. So most trials, there's a placebo arm or a sugar pill or a sham treatment that's involved with that. And so you may or may not receive the treatment. So you may or may not benefit, but this potentially benefits us down the road. And so I think that's important to keep that in mind. So don't do it because there's nothing else that works for me. Do it because you want to advance our knowledge and what is going to help people down the road. A lot of trials, though, you should be asking, is there an open label extension? So a lot of trials will offer at the end of whatever the specified period of time is then you can roll over if you'd wish to the active treatment. So you may potentially then get the treatment down the road. So that's a good question to ask if you're interested.
Say that again. What was the name they should ask?
The open label. Is there an open label extension? Is there an extension to the trial where I would get treatment? And then, you know, how frequent are the treatments? You know, if you live 5 hours away and you have to come every 2 weeks for a year, maybe that's not for you. So I kind of understanding what your commitment to that is, because, you know, you can always drop out of a trial, but we really want to keep people in the whole trial if we can to better understand this. So, you know, making sure you have the amount of time and the time commitment to do those trials. And then asking too about what are the potential side effects, you know? So it's important to know those sorts of things.
What's the length of time? Like how many weeks, months would a typical
Yeah,
medication?
that really varies from trial to trial. I would say probably the shortest trials would be about 12 weeks, so 3 months. And you're probably in those cases going to be seen really, really frequently. There are other trials that are going out for 6 months or a year or even longer. And the open label extensions are going out usually for several years, trying to get an idea of do these treatments continue to work long term, or are there any side effects that pop up or concerns that pop up. But generally speaking, I'd say 6 to 12 months would be an average trial length.
Okay. And then how does that incorporate into the whole timeline of getting a new drug available?
Right. So new drugs it's tricky. So you have to go through, first of all, they have to go through animal trials to show that the concept is potentially useful for human beings. And we don't always know that just because it worked in a mouse or in a primate, that this is going to necessarily work in humans. And once we kind of come up with, hey, this looks pretty promising, then they have to go through phase 1 trials, which are safety trials, essentially, where a small number of people are given this and we look for any major bad things that could happen. A lot of times phase 1 trials might be given in actually healthy controls, people that don't have the disease, although sometimes they are also done in people with the disease. Phase 2 trials, so that takes a period of time to get through a phase 1 trial. Phase 2 trials are really a safety, but also looking at what dosage do we think is going to help or not help, and is there evidence that this may be a helpful medication going forward. So there's more people in a phase 2 trial. These are people that have the disease that would be in these trials. If that trial looks good, then we have to go on to a phase 3 trial. Phase 3 trials are done on a large population of people with the disease. And this is looking still at safety, but primarily now we're looking at, does this actually work? And if it works, what dosage actually works? And so by the time that you enroll a phase 1 trial, a phase 2 trial, a phase 3 trial, after you get everybody enrolled, the number of people that you've decided you need to show an effect, then you have to get to the end of those trials in phase 1, then phase 2, then phase 3. And so it's many years. And then after that, it gets submitted to the FDA for the FDA to say, oh, let's take a real hard look at this. And that usually takes 6 to 12 months. And after it's submitted to the FDA. And so that's why it takes so long. And so actually a lot of treatments get delayed because of enrollment issues. And so if we're not enrolling these trials, it's going to take even longer to get to that endpoint.
Deep breath there as I'm just calculating all the time that it takes. But I mean, there's hope. We have new things on the horizon.
Yeah, I think there's lots to be hopeful for right now. Better treatments potentially, as well as, can we modify the course of this disease, which is a really big deal.
Wow. Well, thank you so much, Dr. Harlow, as you were rapid firing, answer after answer to all our questions today. And our hour has come up. And I just thank everyone for joining us today. Dr. Harlow, thank you so much for your time and energy into this program today.
Absolutely. Thank you for having me. And thanks for everybody for joining us.
Yes. I just have 2 last things to share. Make sure check out our website at parkinson.org for more information and our helpline. We're here to answer questions. You'll speak with a Parkinson specialist. So anything that came up today that we didn't have time for, you are welcome to call or email them as well. And I'd love to have you guys join us for an upcoming program. We're doing newly diagnosed. You are not alone. So people who are recently diagnosed or anyone, who's just coming to terms with what Parkinson's is, even 8-10 years after that diagnosis, some people are still just getting used to what that means. And then we also have some exciting October programs for Wellness Wednesdays. We have abstract art. This one should be super awesome. You get to be involved in bringing your materials, and we're going to do a Zoom project so then everybody holds up their artwork and it creates a big mural on the screen. The following, we have Sing Out for Parkinson's. The 21st, Share Your Story. And then the 28th is Shakespeare for Parkinson's. So can you imagine reading sonnets from Shakespeare and moving your body and practicing your vocal techniques? It should be a lot of fun. So I'd love for you guys to join us then. And until then, we hope you all enjoyed today's program and that we could see you in the future, and have a wonderful rest of your day. Take care.